And I just wanted to title my slide somewhat differently from everybody because I don't have one special project. As he said, I look at different questions and different answers and move on with that. So basically, I just want to tell you that now as a research, I'm not a researcher. I am a faculty in oral biology with major emphasis on teaching, and I have 10% probably time to do research in a week. I know I don't have so much time, but I am involved in a lot of prospective, actually not very many prospective studies, retrospective studies and educational research. Nowadays I'm doing some educational research as well as some retrospective studies. So I'll just go through the different studies I've done over the years because I've been here 18 years. So it's Nebraska Good Life is treating me well. So, you will see that this was one of my first projects in 2005. I did variations in the microscopic morphology of odontogenic keratosis. This was my study with Dr. Casey and somebody else, and this was basically we submitted this particular study for a IADR meeting, and I went and presented the topic there because it was accepted for an oral presentation. So I just wanted to show you some of the OKC variations. So people, actually I have to put it out as a paper, which I still haven't done, but that is my to-do list of there is variations in OKC histology, and that is, there are classic areas in the cyst lining, but there are other areas. So we also found mucous metaplasia, which was never told about before. So we found it, and we also saw some cilia, so which was so different from routine microscopic definition and description of OKCs. It would have been a good write-up, but I'm such a lazy bum, so I can't do anything about it. So here, sometimes you see only the cartilaginous change in the stromal area. So we have had a couple of cases. After doing the study, I could tell the clinician, yeah, you did the biopsy, but I didn't see the OKC lining, but I saw the stromal change, which resembled cartilage, so it may be an OKC. And he did another biopsy later on, and it was an OKC. So that was good to, I learned from it, though I didn't put it out for everybody to know what I did. So we had...
Nagamani, just a quick question. In the previous side, was it lymphocyte infiltration on the OKC side?
What's that?
On the cartilaginous...
Fibromyxoid change.
No, on the right hand, in the cartilaginous changes, all these, basophilic in the stroma, all these dots.
That is the lymphocytes.
Lymphocytes, okay.
There is some infiltration of inflammation, though you are not supposed to see inflammation in an OKC because it's a developmental cyst, but there are areas in the cyst which can get inflamed. So that is the change that you will see. And here you are seeing a lot of satellite cysts, and the top lining is not very specific, and there are areas of parakeratinization and orthokeratinization and cystic lining with calcification. So these are all present, and so we saw that mucous cells were present in 9.6% of the cases, cilia was in 4%, and cartilage was in 4. So we did a study about the male and female, and there was a bimodal age population, so 41 to 60 and 61 to 80, there is an increase in the number of patients at this time. So we had about 250 cases. So the important thing I put it out in the IADR meeting was it was more common in the mandible. Everybody knows that. Average age was 47, and metaplasia is more common than previously thought of, and stromal changes are important as well. So this was found at that time. And that was the basic reason why I did it was for a new pathologist, you may find that you may have to diagnose OKC with limited sample, so you need to know what are the different variations you can get. So I'm kind of sitting on a gold mine with all the archival material. That's why I don't throw anything out. And this was a study I did in 2005 with my students. These were star students who were in hygiene. And at that time, the over-the-counter new mouthwash had come about, Crest Pro Health. So, and I really helped them, very little help, but they did the major study, and we recruited 98 patients to do this particular study and looked for mouthwash changes on the oral mucosa. So this was a prospective study, and we got IRB. We got their approval on the on these things. So that was good. So here, informed consent was gotten, and then we had Listerine and Crest Pro Health, which was available in the school at that time. So we were able to use that. And we didn't get any money or anything from any student project or anything. This was done outside the project, but these students, again, went and presented their information at the IADR in Australia at that time. So it was unknown that hygiene students can go for an IADR meeting and present the result. So, and they won their thing even in the summer student project award also they got. So this was a study we did, and we had inclusion criteria and exclusion criteria, and we asked them to use twice daily for 1 month, and then we looked at the statistically significant, there was statistical significance between Crest Pro Health and Listerine. Crest Pro Health was better than Listerine. And this was a project which they presented at the IADR, and the student came back and told me, you know, the Listerine people were fighting with her because she was giving them this particular information. So she was little upset about it, but I said, yeah, that is the thing, you know, we are okay with upsetting people. And so you can see that there were changes in the clinically in the mouth. So we did this study over a month, and patients used it, and we looked at all these changes. There were petechiae and white areas in the palate. So hard palate had more lesions compared to any other location, and there were red areas and white areas. We didn't biopsy any of them because we had a thing in the IRB that we will biopsy if any lesion was present 2 weeks after we saw it, and none of them were there after 2 weeks of withdrawal of the medication, of the rinse. they were okay. So this was one of our prospective studies, and no biopsies were needed. And they all liked Crestro Health at that time. So it would have been good if I had sent in the written thing and published it, but I didn't. Hey, I'm a lazy one. So these are the changes that you can see in the oral mucosa because of the rinse. So sometimes patients can come in with all these changes, and we as oral pathologists will be thinking of bigger problems rather than small things. So asking the right questions will help to answer that. So that is what we wanted to tell them, that use professional judgment when you're telling your patient which one to use, which solution to mouthwash to use and things like that. But these were our limitation because it was only for a 1 month duration, a small sample size compared to 98 is a small sample size, and that was a problem. And then I did studies on this particular thing, microscopic features of tobacco pouch lesions, because the question is really chewing tobacco better than smoking? If you ask that question, and the US Department of Tobacco says, yes, tobacco chewing is better than smoking. So I wanted to do a study to answer that question, and we looked at all our retrospective cases where the specific aim was to describe the microscopic changes, because in the books you'll see that they should have chevrons, they should have eosinophilic coagulum around the minor salivary glands and things like that. But how many times do we see it? Not very many times. So I just wanted to see what is the pattern of the microscopic changes and patterns of hyperkeratinization, and identify the frequency of these lesions with age and gender. So we looked at this and we did the IRB, and this was one of our student projects, and the students got the summer award for this project. And then we looked at the chevrons, and they were there only in few cases, not every case. So the books keep saying, oh, there has to be chevrons. Not every case will have chevrons, and there are mixed type of different dysplasia was seen, but only in few cases. So mild dysplasia was noted, and this was a moderate dysplasia, mild to moderate dysplasia, because dysplasia up to middle of the epithelium, we call it moderate, so this was moderate dysplasia. And this is the eosinophilic coagulum. So it was not present in every case. It depends upon the depth of the biopsy. Not everybody does a deeper biopsy for diagnosing tobacco pouch keratosis, and maybe they won't do a biopsy either because it's so clinically representative. So anyway, this was seen only in few of the cases. So we saw that males were more often using tobacco chewing tobacco compared to others. And sometimes the accuracy of the diagnosis was also not there. There were 13% of cases came in saying tobacco pouch keratosis, which were not tobacco pouch keratosis at all. So that is another problem. So there is a problem with accuracy of clinical diagnosis. So we found that edematous hyperkeratosis is the most common type of hyperkeratosis. Chevrons were noted only in 18% of the cases, and eosinophilic BAM was seen only in 1 to 5% of the cases. So dysplasia was present in 6% of the cases and mostly in the verruciform hyperkeratosis. And so this kind of said, yeah, tobacco pouch keratosis is better than, or chewing tobacco is better than smoking tobacco. So that answered that question, and I presented this at a tobacco meeting, and then there was a patient there who came up and started fighting with me and saying, oh, you don't know, I have cancer, developed from chewing tobacco. I said, yeah, there may be other things. I'm just talking about what I found in my study. And there are about 250 cases, and this is all I could tell you, but I don't know what happened to you. So this is another study which answered one of the questions. And we did this retrospective. As I told you, I have done a lot of retrospective studies, and this was a minor salivary gland sialolithiasis, which is not a common diagnosis because people don't think about it in the minor salivary glands, because it's common in the major glands, because they usually patients will complain of pain on eating anything, and then swelling happens in the floor of the mouth, and you will see a big stone. That is the common appearance. But sialolithiasis can happen in the minor salivary glands, which is unusual. So we went through our archival material, and we got the UNMC IRB. So I'm proficient in getting expedited IRB. So then if you look at it, you see they are smaller in size, more common in man, age 66 and is the common age for so it is more common in the elderly. So upper lip occurs more common than buccal mucosa or lower lip. So I was checking for the accuracy of diagnosis, and I found that there were only 25% of the time people diagnosed it as sialolithiasis or stone. So it was not a common diagnosis, and the size was bigger if it was in the buccal mucosa. And this was one of the slides which I wanted to show you, because I presented this particular information at my AAOMP meeting, annual meeting, and somebody came up and said, what a great slide. That was a good slide. I said, yeah, I took it. But she was like, no, it's not you. It is the histotech who did that. So you have to go and tell them how beautiful the slide was. So I said, I took the slide, a photograph, but no. Anyway, so this was only 19% of cases were diagnosed properly, and this particular study, I published it finally. Anyway, so that was one of those. And this was my very early study, which I did with Dr. Naushad, and we were doing this study long time ago, 2005 or 6, I think. So we actually went with this presentation to UNMC and during the Midwest thing as well, and they won $100 for that. So anyway, we did the study, and there was a problem with staining. Sometimes the immunoperoxidase didn't work very well in our hands at that time. So that was that. And I worked with Dr. Wall with numerous studies on looking at leukoplakias and desmoplakin and squamous cell carcinoma. We found variations depending on dysplasia and squamous cell carcinoma, and we published one of the one article on that. So we did desmoglein, desmoplakin, plakophilin. We did all kinds of different stains, and this was actually immunofluorescent dye rather than immunoperoxidase. So we did that particular study. And then this was another study which we did with our students long 2010 probably, I don't know. I've done so many studies, I've forgotten what I've done or not, because this was on misdiagnosis of lateral periodontal cyst, because a lot of times people will say lateral periodontal cyst when it is not. So we went through every case that came in as lateral periodontal cyst and found what was the diagnosis, and we found only 12.3% of the cases were properly diagnosed. So that was a good thing, and they should have been done as a paper, but didn't do. So, and I presented it at a meeting. So basically looking at peripheral calcifying cystic odontogenic tumor, which is not very common, it is rare, and I had one case and then there was another case in the archival material, so we put it together and took it as a poster in one of the meetings. So this was also a long time ago, so if you look at the logo, then you'll know this is not today that we did this, it was a long time ago. And then I thought about accuracy, because that was becoming my major interest, to know how accurate are the clinicians. So we did an accuracy study on certain common lesions like periapical lesions and fibromas and squamous cell carcinomas, papillomas and things like that. And I found that there was, it was not very good. It was every time you get the biopsy requisition saying deferred biopsy, they don't give us the clinical diagnosis. So we need to improve on accuracy. So I know that. So I've been trying to teach that to the students. So I learn things from my research and apply it for teaching. So then this was extragingival pyogenic granuloma 3 years ago. We did this study, and it won the summer project award for the student, and I felt very sad for the student because he had sent in this abstract before and it was accepted for the IADR in Vancouver. And we had to withdraw the project at that time because he won the a summer student award. So he would go to Washington, D.C. in 2019, 2020. But it didn't happen. He lost going to any meeting. So I felt very sad for him. But he did the study on the extragingival pyogenic granulomas because our main question was, is pyogenic granuloma occurring in other areas other than the gingiva? Because everybody knows it has to appear on the gingiva, but it can it appear anywhere else? It does, and most common is the tongue. So the important thing is to add to your diagnostic ability. So it is, when you see a nodule which is ulcerated, you have to think of pyogenic granuloma as well. So this adds to the diagnosis as well. So a lot of studies have been done, and this was another study which I did myself because I just wanted to look at USP6 translocation in giant cell granulomas because they said that USP is, this is a thing which changes in aneurysmal bone cyst and long bones, giant cell granulomas, but it is not changed in the oral cavity, so it is a reparative lesion, it is not a tumor. So that was good to find out. And I have done some collaborative work with my friend who is in Tufts, and she presented this paper in the AAOMS, that is the oral surgery meeting last year, and we got this particular paper done. So we still are waiting to publish it. And so now, for the past couple of years, I've done some educational research. So in 2017, they said, the school UNMC was going to go to Apple, and we'll all get Apple training. So we got Apple training, and on Apple and iPad, everybody was going to use an iPad. So that was the thinking at that time. So I developed a lot of I modules on different things, and we got UNMC expedited IRB, and iPad, all these were put on the canvas or blackboard, depending on whichever we were using at that time. And then this was one of the iBook, Differential Diagnosis of White Lesions, and this got converted into Articulate. Now it's on UNMC eGallery, so people can go in and look at it and learn about the white lesions. I thought it is important that people understand all white lesions are not leukoplakia. So we did another study on that. All white lesions are not leukoplakia, and then we sent it to general dentistry, and they said they accepted it. So we don't know where it is in the whole slew of things. Now it has been accepted for publication, and I don't know where it is sitting. So we found that post-test, they all did pretty well compared to the pre-test. And then I wanted to tell the dentist that pregnancy is not a disease, and you can treat these patients. So I wanted the students to understand that. So we did a e-module on pregnancy, and then we got good pre-test and post-test, and there was a lot of difference and statistically different difference between the pre-test and the post-test. And there a lot of people loved the survey. When we did the survey, they liked the iModule. We had worked on the dry mouth as well, because dry mouth is another problem which students need to know how to manage dry mouth in everyday practice. So I thought this was a good thing to tell them and put it on the iModule. So here, this was the dental management of a cardiac patient. So this was done as an RFA for UNMC, and this got the award at that time. This was the the second round of UNMC putting out the RFA, and then we did the study later on, and we saw that D3 and D4 students did better than D2 because they didn't have any aspect of cardiac patient information before, and female students did better than male students. So here you can see the pre-score and the post-score, how women did better. So I thought women like to do better on e-modules. I don't know. So I have to figure out why that is happening. So that's another question that has to be answered. Maybe they spent more time on the e-module based on my evaluation. So now this year, I'm doing our dentists responsible for opioid crisis. This is a summer project which won the award, where has the money. So there are 2 students who are looking at it, and I think this is timely. We need to know whether we are prescribing more opioids, and from the initial evaluations, it looks like we are not giving them too much opioids in the school. We give it only during the third molar extractions rather than any time, and it's only for 5 days. So I don't think that will result in opioid crisis, but it's always the dentist. Any problem, they'll blame the dentist. So that is important to remember. And Dr. Meehan and myself are looking at the incidence of dental emergencies at the College of Dentistry. So we are doing a 10-year retrospective study. We got an IRB, so we are still trying to look at the all the findings and go through it.